Usmle style question, severe combined immunodeficiency CID. A 2-month-old infant is brought to the pediatrician due to a history of recurrent infections. The infant has had multiple episodes of pneumonia, diarrhea, and oral thrush since birth. The parents are concerned that the baby has not yet received routine vaccinations. Physical examination reveals failure to thrive, oral thrush, and lymphadenopathy. Laboratory studies show absence of detectable T-cell markers and normal B-cell counts. The patient has a normal IgM level but low IgG and IgA levels. Which of the following is the most likely diagnosis? A. X-linked agammaglobulinemia. B. Severe combined immunodeficiency. C. Chronic granulomatous disease. D. Wiskott-Aldrich syndrome. E. DeGeorge syndrome. Severe combined immunodeficiency. Explanation: this infant's presentation is characteristic of severe combined immunodeficiency, a group of disorders caused by defective T-cell and B-cell function. Scid is characterized by recurrent severe infections, e.g. pneumonia, diarrhea, oral thrush in the first few months of life, failure to thrive due to the immunodeficiency. Absence of T-cell markers, no proper T-cell function leading to an absence of cell-mediated immunity. Normal B-cell counts, but defective humoral immunity, e.g. low IgG and IgA. Absent or decreased response to vaccination due to the lack of functioning T-cells. Scid can be caused by several genetic defects, including mutations in the IL-2RG gene, X-linked, ADA gene, autosomal recessive, or others. Why other choices are incorrect? A. X-linked agammaglobulinemia. This disorder is caused by a mutation in the BTK gene and results in absence of B cells, leading to a lack of antibodies, immunoglobulins. However, T-cell function is typically normal, so T-cell markers would not be absent. The absence of T-cells in this case makes X-linked agammaglobulinemia unlikely. C. Chronic granulomatous disease. This disease is caused by a defect in phagocytic cells, e.g. neutrophils and macrophages, due to mutations in the NADPH oxidase complex. It results in recurrent bacterial and fungal infections, but it does not lead to T-cell deficiency or absence of T-cell markers, which are seen in Scid. D. Wiskott-Aldrich syndrome. This condition is characterized by eczema, thrombocytopenia, and recurrent infections. It is due to a mutation in the WAS gene, X-linked, and leads to abnormal T-cell function. But there is normal B-cell function. The absence of T-cell markers would be unusual in Wiskott-Aldrich syndrome, making it less likely here. E. DeGeorge syndrome. DeGeorge syndrome is caused by a 22q11.2 deletion and results in thymic aplasia and T-cell deficiency. However, it is typically associated with hypocalcemia, congenital heart defects, and parathyroid hypoplasia. While T-cell deficiency is a feature, the patient in this case does not have the characteristic cardiac malformations or hypocalcemia, making DeGeorge syndrome less likely. Clinical relevance. Scid is a life-threatening genetic disorder of the immune system that is present at birth and is caused by mutations leading to impaired T-cell and B-cell function. It is one of the most severe immunodeficiencies. Diagnosis: absence of T-cells and immunoglobulin abnormalities, low IgG and IgA levels, are diagnostic. Confirmatory tests include testing for mutations in the IL-2RG gene or other Scid-associated mutations. Management: bone marrow transplant, the preferred treatment for most forms of Scid. Gene therapy is also being developed for certain forms of Scid. Preventive measures include strict isolation and early stem cell transplant to prevent life-threatening infections.